a general surgeon, assistant professor, and he's especially a breast surgeon. He's working at Hyderabad Medical Complex, Peshawar. Thank you for joining us, Dr. Amjad. We are also joined by Dr. Mansoor Ali Khan, who is a plastic surgeon working in Hyderabad Medical Complex, Peshawar. Thank you, both of the faculty members. And today we are unfortunate we are not joined by Professor Muzaffaruddin Sadiq. He is busy somewhere else, so hopefully he will join us in the next session, inshallah. So from now onwards, we should start the session formally. And I invite the presenter, Dr. Farah Naz, our presenter for today's case. She's a fourth-year resident, Surgical C Unit, Khyber Teaching Hospital, Peshawar. And the conveners again of the session would be Dr. Maria Mirjan and Dr. Maham Qazi. So let's start the case now.
Assalamu alaikum to everyone. Am I audible to everyone?
Yes, Farah, you can.
I am Dr. Farah Naz, resident surgical C ward. Today we will discuss a case on early breast carcinoma. Next, please. Mrs. X, a 39 years old lady with no comorbids from Swat, presented to us in OPD with the chief complaints of left breast lump from the last 7 months. According to the patient, she was fine, doing very fine 7 months back when she suddenly noticed a painless lump in her left breast from the last 6 months. The lump was noticed while she was washing herself. Initially, according to the patient, the lump was pea-sized, but then it, over the time, as the time was passing, it gradually increased in size and has become becoming harder. And these were the main reasons which compelled her to seek her first visit to seek a consultant for her presenting complaints. No previous consultation was made regarding her complaints. There was no size fluctuation. Maria, can you please show the previous slide?
Sorry.
According to a patient, there was no size fluctuation in relation to the menstrual cycle in the lump, no associated nipple discharge, or no other complaints of lump in the breast or any other part of the body. Next. When I inquired her about any associated symptoms, she denies any history of shortness of breath, jaundice, or backache, and there was no fever history. She couldn't recall any history of trauma to the breast. Her drug history shows, she said that she was on OCP from the last 2.5 years, and she has no known allergies. Her personal history, she said that she is married from the last 13 years, having 4 kids. Her first baby was born at the age of 27 years. Last baby born was 4 years ago. All kids were breastfed for 1.5 years. Her bowel habits were normal. Appetite is normal with no specific diet aversions or any specific dietary changes. There was no history of active or passive smoking, no alcohol addiction. Her past history was not significant for any breast biopsies or any kind of mammograms, but she underwent laparoscopic cholecystectomy 2 years back, and her post and pre-op course was uneventful. History of radiation was negative. Her menstrual history, on inquiring her menstrual history, she said she attained menarche at the age of 12 years. Her menstrual cycle is 7/30 with regular cycle. There was no heavy or oligomenorrhea or polymenorrhea history. Her LMP was 16 was on the 16 June 2020. On inquiring about her family history, she said that one of her maternal cousin was diagnosed with CA breast at the age of 45 years, for which she underwent mastectomy, and now she is doing fine. I asked about any biopsies or any results, but she said she could only told me that her cousin only went mastectomy. There was no family history of any ovarian, colonic, prostatic, gastric, and pancreatic cancers. Her socioeconomic history is satisfactory. She and her husband are both school teachers living with their 4 kids in their own home. On systemic review, there was no history of headache, dizziness, loss of consciousness, or fits. CVS was unremarkable on asking about the respiratory system, though there was no history of cough and shortness of breath. No significant history of weight loss was present, no jaundice, no abdominal pain, or any distension. Genitourinary system and muscular system, skeletal system was also unremarkable with no history of muscular, bone pains, or joint pains. Her gynecological history showed regular menstrual cycles. Next. According summarized history, the Mrs. X, 39 years old, married lady from Swat, having 4 children and with no comorbids, presented with history of progressively enlarging painless lump in the left breast from the last 7 months. There is no history of nipple discharge, shortness of breath, jaundice, or backache. There is no history of weight loss. She is having normal menstrual cycle. Family history is positive for CA breast. Systemic review was unremarkable. Differential diagnosis could be CA breast, traumatic fat necrosis, chronic intramammary abscess, fibroadenosis, or any fibroadenoma. Uh, Next.
Okay.
On general physical examination, patient is examined in a well-lit room in the presence of a female chaperone after taking informed consent and fully explaining the steps of examination. Her GP, on GP, a lady in her late 30s with normal build, sitting comfortably on a couch and well oriented in time, place, and person. Her pulse was 80 beats per minute and regular. BP with a BP of 110 by 70, respiratory rate of 14 per minute, and she is afebrile. Breast examination on inspection with the arms on side. Both breasts look symmetrical with normal overlying skin and no visible edema, ulceration, or any kind of skin nodules. Nipples, the left nipple showed circumferential retraction with no active discharge. The right nipple is normal in size and shape. Areola of both sides were normal size and shape, no cracks, fissures, or ulcer, and there was no active discharge. On asking the patient to raise her arms above her head, left nipple raised to a higher level than the right nipple. But there was no dimpling or any puckering of skin or color changes. On leaning forward, breasts fall equally on both sides. On palpation, there was no rise in local temperature in both breasts. Right breast, axilla, supraclavicular fossa, and right upper limb are normal on palpation with no significant abnormality. The left breast was non-tender, left nipple 1 centimeter higher than the right nipple. Left nipple was circumferentially retracted and could not be corrected by pressing on its base. Areola, left areola normal. On palpation of the left breast, about 4 into 4 centimeter non-tender, well-defined, irregularly shaped lump with stony hard consistency is noted in the upper outer quadrant. Lump is about 2 centimeter lateral to the nipple. The lump is fixed to the breast but not fixed to the skin and chest wall. No threatening of skin is seen. There is no discharge from the left nipple. On examination of the left axilla, no positive findings are present on inspection, but on palpation about 2 into 1 centimeter mobile and non-tender but hard lymph node is noted in the interior region. Left supraclavicular fossa and upper limb are normal. A systemic examination on palpating her abdomen, the abdomen was soft, non-tender, with no hepatomegaly or ascites. Chest had normal vesicular breathing, clear auscultation with no signs of any decreased breath sounds. CNS intact, no abnormality detected. CVS was normal with no significant findings. Skull and spine, normal examination, no tenderness could be elicited. Case summary on examination, my patient in her late 30s with normal build has a non-tender stony hard lump of about 4 into 4 centimeter in size in the upper outer quarter of the left breast. The lump is fixed to the breast tissue but not to the overlying skin and underlying chest wall. Her left nipple is retracted circumferentially but there is no discharge from it. She has a mobile, non-tender and hard lymph node of about 2 into 1 centimeter palpable in the left axilla. Left supraclavicular fossa and arm are normal. Right breast, axilla, supraclavicular fossa and arm are all normal on examination. The rest of her systemic examination is unremarkable. Clinical diagnosis, 39 years old lady from Swat having left CA breast of stage 2B, clinical T2, clinical N1 and clinically M0. Thank you.
Now over to Dr. Amjad Ali.
First of all, sir, I would say excellent presentation, a very detailed, very thorough, and not just unnecessary detail. It was to the point. So before we go on to the long case in question, I would like to give some positive feedback. The symptoms were explained really well, and the risk assessment, which is very important. If you are suspecting that someone might have breast cancer, you need to assess their risk of possibly having a breast cancer. And she explained it really well, the personal risk, the personal history for the risk, and also the family history. Examination, everything was very good, so well done. Next, how long do I have, sir?
You have enough time, Amjad. There's no restriction on timings, but unfortunately we can't see you, so please start your video also.
Okay, sorry. I think it's... My video is on. Can anyone see me?
Yes, I can see you, sir.
Okay.
Maria,
okay.
can you help me? The
My video
examiner should be visible to all audience.
So can we proceed, sir?
Yeah.
Okay. So what's your next step? What are you going to do with this patient from here on in?
According to the, I'll go for triple assessment of the patient as history and the examination part are done. Now I'll go for the imaging. As the patient is more than 35 years old, I would like to do a mammogram of the left and the both left and right breast, plus ultra.
If this patient was less than 35, suppose this patient was 32 years old, would you not do a mammogram?
Then a mammogram, then ultrasound would be more specific for that age, as the breasts are more dense, and the denser as the mammogram, the lesion and the dense breast tissue looks same. They both look white, so we can't exactly differentiate the dense breast tissue and the lesion. That's why we will go for ultrasound in the younger age groups and a mammogram for the above 35 years age.
Okay, so is there any indication for doing mammogram in someone who's less than 35? What are the indications for doing mammogram in someone who's less than 35?
Less than 35, if she has any family history, high risk. I think that in that case we would go for MRI, or would it test for MRI the younger age group?
Okay, let me help you here. The guidelines for not doing mammogram below 35 are those for screening. They are not for symptomatic patients. So you have to differentiate between the two. And especially, there are two very clear indications for doing mammogram at any age. One is, if patient is below 35 and you do an ultrasound scan, and ultrasound shows findings suspicious of a possible malignancy, you have to do a mammogram. regardless of whatever information the mammogram can give you. And the second one is, if you clinically suspect someone to have cancer, then age becomes irrelevant. So in these two scenarios, age becomes irrelevant. You have to do a mammogram if you're suspecting a cancer, either on ultrasound or on your clinical assessment. Okay, so you did a mammogram in ultrasound. Are you familiar with the BIRAD system?
Yes, I'm familiar with the BIRAD system. It has six steps with the BIRAD 1 to 6.
Okay, so BIRAD is a bit complicated. There's a simpler version and probably for another time, but are you familiar with the UK 5-point system, which is easy to remember than the BIRAD? So if you did an ultrasound and a mammogram, and the mammogram comes back to be, this is a BIRAD 4 on the mammogram, and on the ultrasound scan, it's a U4 as well. What will be your next step?
It would be if it's a BIRAD 4 on a mammogram, then it would be suspicious for breast cancer and biopsy would be recommended. The BIRAD 4 is further divided into 4A, low suspicion for malignancy. In that, there is greater than 2% to less than 10% of chances of malignancy. So biopsy would be recommended in that case because it is suspicious for breast cancer.
Which type biopsy would you do?
Core biopsy. I would like to do a core biopsy.
Core biopsy
Of the breast lesion or the suspected lesion.
okay, anything you'd like to do?
Core biopsy with the receptors, ER/PR receptors.
Breast biopsy is done. Would you like to do anything else? At this the patient is with the interventional radiologist doing ultrasound guided or clinical core biopsy of the breast lump. Do you want anything else?
I would also like to stage the axilla by doing ultrasound.
Okay. So what are the suspicious findings? If you look at the lymph nodes, what are the features about the lymph nodes which make them suspicious to have possible disease?
Suspicion of lymph node would be the loss of fatty hilum along the lymph node. The malignant is taller than wider. It would be irregular in shape. Maybe there is some fixity if it is advanced. I guess.
What about the size cutoff? What is the size cutoff for axillary lymph node before it becomes suspicious?
Before it on biopsy or on ultrasound?
On ultrasound.
So more than a centimeter when it becomes more than a centimeter then it becomes suspicious.
Good. So a lymph node more than a centimeter with loss of fatty hilum, irregular appearance, and if you can throw in one more, that is cortical thickness. So if cortical thickness of the lymph node is more than 2 to 3 millimeter, it becomes suspicious. So this patient has it, according to clinical examination, has a 2 centimeter lymph node. So most likely it is suspicious. But what if ultrasound comes back and it shows that the lymph nodes appear normal?
If the lymph nodes appear normal, then we can do a core biopsy or FNC of the lymph node.
You would still do.
If the patient is malignant and we are still suspecting not the findings are not correlating with the ultrasound findings, then I think we should go for the FNC and core biopsies of the suspicious nodule.
Okay, so let me make it a little clear. You've done core biopsy of the breast lump, you've sent it for receptors, all well done. The ultrasound scan shows that the lymph nodes look normal. So where do you go from here? This is how far you are. So what do you want to do next?
Sir, if there, according to NCC guidelines, if there are lymph nodes, you should do FNSC or core biopsy. If that came out to be positive, then in the management, you can go for the axillary dissection. Or if in the FNSC negative, then you should go for a sentinel lymph node biopsy during the surgery. You are planning the surgery.
you would do, then ultrasound becomes irrelevant. Ultrasound of axilla becomes irrelevant because you're doing FNA and core biopsy for positive nodes on ultrasound and for normal looking nodes on ultrasound as well. So that means there's no point in doing ultrasound of the axilla.
Okay, sir. So you think, sir, we should not go for an ultrasound of the axilla to stage it?
No, that's not what I'm saying. I'm asking a question. You rightly done ultrasound scan for the axilla to look for the lymph nodes. The lymph nodes appear abnormal, then you do biopsy. If they appear normal, if you're still doing biopsy, that's my question. If you're still doing biopsy, if the lymph nodes are normal, then what's the point of doing ultrasound scan? Because that becomes irrelevant.
So if
Let's proceed. So the ultrasound of the axilla is normal, and now you're in the treatment planning phase. So, what is your plan for this patient? What do you want to do? She has come back with a grade 3 invasive ductal carcinoma. Histology, grade 3 invasive ductal carcinoma. She's sitting in your clinic. What do you want to do next?
So I would like to do, as the lump is not that big, 4 centimeters, she has 2 options now. And the invasive ductal carcinoma, either she can go for a breast conservative surgery or for a mastectomy, MRM, modified radical mastectomy.
Okay.
We can counsel her for both, with as the long-term survival with both mastectomy and breast conservative surgery not that different. There's not much difference in long-term survival in breast conservative surgery and mastectomy. So we can counsel her for both. But if the breast conservative surgery can be done for the patients whose tumor to breast ratio is less, and who has no multicentricity, who is compliant to the follow-up of radiotherapy, as radiotherapy will be needed for the breast conservative surgery. So we can offer.
What if this was invasive lobular carcinoma? What would you do then?
Invasive lobular carcinoma, for it I would go for a mastectomy, because it most of the time it is multicentric, or it can be bilateral.
She's interested in breast conservation. She wants breast conservation. What would you do?
So we can offer her chemotherapy to downstage the tumor.
How sensitive is invasive lobular carcinoma to chemotherapy?
That I don't know. Sorry.
Okay. So the invasive lobular carcinoma, purely there are a few things. One is it can be multifocal, multicentric, but more importantly, the size of invasive lobular carcinoma is very difficult to assess on mammogram and ultrasound. So if a patient is insisting on breast conservation for invasive lobular carcinoma, you can offer them MRI scan of the breast, which will give you accurate size. So let's move on to what is the difference between grade and stage of breast cancer? What do you understand by grade and stage?
Grading is based on the histopathological report, while staging we do on the size, nodal status, and metastatic region of the tumor. So grading.
Breast cancer.
Sorry, sir.
How many grades are there of breast cancer?
3 grades, sir. Grade 1 to 3, well differentiated, moderately differentiated, poorly differentiated.
And what does that tell you? How is a grade 1 cancer different from a grade 3 cancer?
Grade 1 cancer will have a good prognosis as compared to a grade 3 cancer. That would be his.
Yes, it will, but okay, let me help you with this. Perhaps I'm not asking it correctly. Grade basically refers to how quickly, how fast tumor cells are multiplying. So in grade 3, that is the fastest multiplying, and in grade 1, that's the slowest multiplying tumor. So what are the different ways in which you stage breast cancer?
There are staging of breast cancer can be done according to TNM staging, or the Manchester staging system. According to
Yes.
According to TNM staging, there are three things we have to do. The tumor, the nodal
Mhm.
stages, and the metastatic deposit.
Okay.
Sir, should I explain all the TNM
Just give me the nodes.
nodes? Okay, the nodes are if NX, it means the regional lymph node cannot be assessed, previously removed or not properly assessed. And not means no lymph nodes at the time of scanning or clinical examination. And one match to the movable epsilateral level 1 and 2 lymph nodes, but they are mobile. And one. Am I right?
What are different levels of nodes? Sorry, I'm cutting in
Oh,
between.
sorry. Levels of node are three levels of node.
Mhm.
Level 1, 2, and 3. Level
Mhm.
1 nodes are infero-lateral to the pectoralis minor. Level 2 nodes are
Fine. So the end staging, do you think that has anything to do with the level of node?
end stage. Yes, sir. And one in N1 we have mobile level 1 and 2 nodes epsilateral and 2. There come no, sir. I think they are not included. Sorry. They have nothing to do with this.
It's simply the number of lymph nodes. So and one is 1 to 3, and 4 and 2 is 4 to 9, and more than 9 positive lymph nodes is N3 disease. Okay. So how do you stage breast cancer? What are the investigations, the recommended investigations for staging a breast cancer?
For the staging the breast cancer, we can do the LFTs. All the basically we should in early stage we should do the baselines like LFTs
No, no,
for any
you just give me the imaging. How would you image the patient to look for metastatic disease?
CT scan of the chest, abdomen, and pelvis.
Mhm.
Bone scan for
Okay.
any bone mets, CT chest for any lung mets, CT abdomen
That's
for liver.
that's fine. Bone scan and CT chest, abdomen, pelvis. That's the recommended. So, do you stage every breast cancer?
No, sir. If there are we are highly suspicious of a cancer. If it's locally advanced cancer, then we see that
So, what are the
if
indications? How would you know? What are the indications? Give me a list of indication where you would do staging for breast cancer.
if ELP is raised, we can go for the staging. If the tumor is locally advanced, bone scan. If ELP is raised,
What is
um,
advanced tumor? What is the
sorry, sir,
definition of locally advanced tumor?
locally advanced tumor, which are either fixed to the chest wall, stage 3 tumors, sir, locally advanced, which are either fixed to the chest wall or to the chest wall or overlying skin involvement is there. So they are locally
So, what
advanced
about,
tumors.
say, for example, a patient has a 6 centimeter tumor which is not fixed to the chest wall or the skin? Would you
Uh,
stage that tumor?
it would be T4 should be an indication for a staging.
Okay, so you've got T3 and T4 tumors. What else is the indication for staging?
Uh, T, um, um, uh, admin,
Okay,
stage, I,
that's
give me
okay. That's okay. You're doing well. Relax. You're doing well. So let's come back to then your case. So you've assessed this patient. This patient has got a 4 centimeter tumor. Axilla on assessment is negative. On clinical examination is positive, but let's presume that it's negative. And ultrasound tells you that axilla does not have involved lymph nodes. And you've got the histology back, which is a grade 3 invasive ductal carcinoma. Your receptors, you've got ER negative, PR negative, and HER2 positive. So this is your case. What would be your recommendation? Where would you go from here?
Sir, if it's we can go for still for a breast conservative treatment with scintillating and lymph node biopsy and transfuse the map for the HER2 receptors. Would be advised.
So your plan, so what are the different modalities in which you treat breast cancer? You've got surgery, you've got chemotherapy, you've got radiotherapy, and you've got endocrine treatment, and then biological and targeted other treatment, other agents. So what do you want to do first to her?
So I would like to do first. I would like to decrease the local to decrease the local disease. So I'll go for a surgery.
So first surgery, okay, then
Then it's a no node and 4 centimeter mass with her two legs. Then after that, we can put her on the targeted endocrine therapy, biological therapy.
on her septal. Okay, so in surgery, you're doing breast conservation surgery
Yes, sir, I will be doing breast conservation.
for the axilla, for the axilla.
For the axilla sentinel and lymph node biopsy,
So, do you know the method, the technique for doing sentinel node biopsy?
yes, sir, the sentinel lymph node biopsy can be done with methylene or lymphocytin dyes or sulfur colloid, any albumin sulfur colloid with a gamma probe. What we do is we inject the dye in the periareolar region subcutaneously at 12 or 6 o'clock position. Then wait for 10 minutes and then dissect the axilla to see if there are any colored nodes or if there is any lymphatics, blue lymphatics going to a node, then we will consider those nodes as positive and we'll take them out and send them for histopathology.
So why do you inject in the periareolar region, subdermal periareolar region? Why there?
Subdermal lymphatics will drain the breast into the axilla. That's why we inject it there for the get the
And
node.
how many lymph nodes do you take out?
At least 10 in sentinel should be there should be at least more than 10 lymph nodes. Sentinel
So-
lymph nodes for sentinel lymph nodes we should take out only the dyed lymph nodes or the hot nodules or any enlarged or hot nodule we should take out for the sentinel.
Okay.
But
Okay.
and then
So good. So you've done breast conservation. So when your histology comes back of your lumpectomy, what would you like to know when you're looking at the? So you've looked at the axilla. We'll look into that later. But they're commenting about the histology of the breast lump that you've excised. You already know that it's a grade 3 tumor. Ultrasound said it was a 4 centimeter. Let's say histology says it's a 4.5 centimeter tumor, and it's a grade 3 tumor. What else do you want to know from the histology?
we would like to I would like to know about the margins. The grade
Okay.
of
Why? What is a safe margin?
at least 1 centimeter, there should be at least 1 centimeter negative margins around the tumor.
1 centimeter according to who?
Sir, in Bailey it said less than 1 mm or 1 to 1 centimeter.
So it's recommended is 1 to 2 millimeter. There are systematic reviews and meta-analysis which shows that if you have more than 1 millimeter margin or 1 millimeter margin, and if you follow it with radiotherapy, it's as good as having a 1 centimeter margin. So your safe margin is minimum 1 millimeter, 1 to 2 millimeter range is fine. So your margins are clear. And your lymph nodes, one of the lymph node shows evidence of metastatic disease. What do you do then?
If there are metastatic disease in the lymph nodes, then we should offer chemotherapy to the patient.
Sorry, I didn't hear that.
If there are evidence of metastatic disease in the axilla, then we should offer chemotherapy to the patient.
Okay.
And
So sentinel node biopsy, is that a treatment procedure for the axilla or is that a staging procedure for the axilla?
it's just a staging procedure for the axilla. Yeah,
So how would you treat a positive axilla then?
we will do axillary lymph node dissection then.
Okay, so you
Then,
were going chemotherapy. So one option is axillary lymph node dissection. Is there another option?
Axillary lymph node dissection. So I guess radiotherapy could be done to the axilla to deal
Yes,
with
but
it.
what's the evidence? Do you know the evidence behind radiotherapy to the axilla?
So like what about the mechanism?
No, no, no. The research study that gives you the evidence it is safe. A trial that is that proves the role of radiotherapy to a positive axilla.
The sorry sir, I can't remember, but I guess it's the 11 trial you're talking about, sir.
No, it's called MROS. If you look at the MROS trial, it will tell you that if you have a smaller tumor with one or two positive nodes, and if you radiate the axilla, it's as good as doing clearance in terms of survival. So coming back to the axilla, um, do you know macrometastasis, micrometastasis in isolated tumor cells?
Sir, micrometastases are less than 0.2 mm and more than it should be more than 0.2 mm but less than 2 mm. These are
Okay.
micro, and greater than 2 mm then comes in the
And
category of
below are
macro.
isolated tumor cells. So how do you manage all of them the same, or is there a difference in the management?
No, if there came out to be micro metastasis, then there is no need for any further axillary lymph node dissection.
Okay.
But if there are macro mets, then we should go for the completion of the axillary lymph node dissection.
Okay. It's getting a little tougher, but you're doing well. That's why it's getting a little tougher. So can you leave one or two positive macrometastases?
Sir,
The sentinel lymph node biopsy showed that you have a lymph node which shows that there is a meter metastatic deposit. Is there any evidence for leaving that axilla without doing anything?
sir, doing radiotherapy would be an option to leave it, but I haven't read any. I don't know about any specific evidence.
Okay. If you get time, if you read the American Z11 trial, it's a trial where they looked at macrometastasis, one or two lymph nodes positive, and what they did was they randomized them into two arms. There is sentinel node biopsy, and those who came back positive randomized them into two arms, one with no further treatment and another one where they treated with conventionally. And what they found was in their 10-year study that there is no difference in survival. The trial is called Z11, Z0011. It's the American trial. There are controversies about the trial, which is why it's not widely accepted. And there is another trial, POSNOC, POSNOC, UK-based trial, which is currently evaluating this. But it's good to know that there is some evidence that you can leave one or two positive macro, but there is some evidence. So coming back to your case, so you're doing surgery. What are the indications for offering a patient neoadjuvant chemotherapy? Why can't we give the patient neoadjuvant chemotherapy instead of going straight into surgery?
Neoadjuvant therapy would do more benefit in a triple negative tumor with no ER, PR, and HER2 receptors, with more than 4 lymph nodes, or when more than 4 lymph nodes came out to be positive, then we can offer them neoadjuvant chemotherapy.
So how would you more than 4 lymph nodes positive unless you do surgery? And if you've done surgery, you can't give neoadjuvant chemotherapy. You've missed the boat.
Yes, but it can be given in node positive cases.
What about HER2 positivity?
HER2, yes, it can. Chemotherapy can be given in neoadjuvant chemotherapy can be given
I,
herself.
yes,
Along,
it is recommended that if a patient is HER2 positive, that patient should have neoadjuvant chemotherapy regardless of the ER/PR status. Triple negative is an indication. So your patient, you have a young 39-year-old patient with a grade 3 tumor with a HER2 positive receptor. So why not neoadjuvant chemotherapy?
yes, sir, we can offer her neoadjuvant chemotherapy. It will also downstage the tumor for us, and then we can go for the breast conservative. Then we can also offer her breast conservative surgery too.
Okay, so now that you know, which one would you go for now, surgery or neoadjuvant chemotherapy?
Neoadjuvant chemotherapy.
Okay, is there anything you would want to do to the tumor before starting neoadjuvant chemotherapy?
Yeah, yes, sir. I would like to mark it with a metallic clip or anything like that. So if the tumor disappears, then at the time of surgery, we exactly know where the tumor was, so that we don't miss that area in.
Excellent, excellent, good, well done. Um, with regards to radiotherapy, do you know the difference? What if this patient does not go for radiotherapy afterwards? What is the downside of not having radiotherapy afterwards?
So, afterwards, she can have recurrence in the same breast.
So there is
For
a of recurrence. Do you know the numbers? What is the difference in local recurrence rate if somebody has radiotherapy afterwards and if somebody skips radiotherapy? What's the difference in the local recurrence rate?
uh, I don't remember the exact numbers.
So with radiotherapy, your 5-year, remember 5-year local recurrence rate with radiotherapy is from 2 to 5%. But without radiotherapy, it's reported to be 15 to 20%. So there's a huge difference in local recurrence rate. So whenever you are counseling a patient for surgery, always say, if you're going for breast conservation surgery, you have to have radiotherapy. Otherwise, you're risking a 15 to 20% increased risk of local recurrence. If they don't want to have radiotherapy, then you should have a mastectomy. What are the contraindications to having radiotherapy?
So the main contraindication would be the patient who is not willing, not complying with the radiotherapy, or
Okay.
if the patient is a pregnant lady in her first and second trimester, mostly.
Good. Good.
If there is multicentricity in the tumor, that would be a relative contraindication, but I guess that comes in a contraindication.
So what I'm saying is you've got a tumor in the breast. So it's a small tumor, you can do breast conservation, but what are the contraindications for radiotherapy then?
Contraindication for specifically for, if there are any if she underwent silicone implants, then that is a contraindication to radiotherapy. Or so are you specifically asking about the radiotherapy contraindication or for the breast conservative surgery?
Breast conservation surgery.
So breast conservation surgery is as the patient will have to go for radiotherapy. If she is non-compliant, we can't offer her breast conservative surgery. If she is a pregnant lady, we can't offer her. If there is a high tumor to breast, low, the tumor is bigger than the breast size, means we can't remove the tumor without distorting the breast architecture, then we can't offer her breast conservative therapy. Multicentricity can be in that case we can't offer her breast conservative therapy, or sir,
Basically,
if there are persistently positive margins on re-excisions, then I guess we can't. We should.
basically all the indications where you cannot offer a patient breast conservation surgery are contraindication. You pushes you towards a mastectomy. So one of the things that I wanted to push you towards was, say this patient has breast conservation surgery, has radiotherapy, has chemotherapy, everything. 3 years down the line, this patient has a local recurrence, and the local recurrence is say 1 to 2 centimeter. You can easily perform another breast conservation surgery with a very good cosmetic outcome. Would you do another breast conservation surgery? No, because you cannot do repeat radiotherapy to the breast. So once a breast is radiated, you can't give, even if the tumor is 1 to 2 centimeter, you have to offer a mastectomy. Are there any indications for doing radiotherapy after mastectomy?
After mastectomy, sir, if there are any radiotherapy to the
A mastectomy on this patient and the histology report comes back, would there be anything in the histology that would compel you to give radiotherapy to this patient?
anything in the histology, sir?
So if all T3, T4 tumors, they would need radiotherapy to the chest wall even after mastectomy. There is consensus that all N2 and 3 disease, those patients would have radiotherapy as well to the axilla. And one, there is a bit of split, but majority of the people say even with N1 disease, you should give radiotherapy to the chest wall. If your tumor is even small, but if it is 1 millimeter or less than 1 millimeter from the posterior margin, from the chest wall, you should still offer radiotherapy to the chest wall. I think that was very comprehensive. You've done really well, excellent, well done. And if there are any questions, I'm free and available for the questions.
Thank you very much, Dr. Amjad, for such a nice discussion. And basically, there was few questions, and Amjad will answer all those questions one by one. But my question to Dr. Farah is that you did mention about one of the investigations, that is mammography. But as a candidate, you are supposed to know a little bit about the findings and which are suggestive of malignancy on mammography.
Sir, findings suggestive of malignancy on mammography are microcalcifications, speculations, or any architectural distortion of the breast, any nipple retraction. So I guess
There are certain features basically in the lump or in the mass which can favor malignancy, and there are certain other secondary findings which can guide you towards the diagnosis. So like you can see skin thickness, there can be single duct dilatation, there can be lymphadenopathy in the axilla, and right. What are the contraindications of, sorry, one of the questions from the audience was that if you're suspecting a malignancy and highly clinical suspicion of malignancy, still you go for the mammography or not?
That question is for me.
Yeah, okay.
Okay, so basically the guideline, some say 35 years, some say 40 years, that you should not do mammography in less than them. And that is only for screening patients, for asymptomatic patients. And the reason is that you're more likely to miss very small tumors. A screening patient by definition is where on examination you cannot feel anything. So you're mainly a few millimeters or a centimeter tumor. So if you're talking about a 4 centimeter tumor, which is palpable and which you think is possibly malignant, I'm sure the mammogram would pick that up. So the two indications for doing mammogram, regardless of whatever the age is, patient of the ultrasound shows findings suspicious of a possible malignancy or clinically expecting a malignancy. These are the indications where it becomes irrelevant and you do a mammogram in anyone.
Yeah. Right. So for candidates who are appearing in part 2, okay, if you are still doing mammography, again, for multicentricity and for bilateral, for the other contralateral side also. So another question for Farah.
yes, sir.
What is the pitfall or the limitation of sentinel lymph node dissection?
Sir, there can be skin necrosis due to intradermal injection of the dye into the skin.
That you are talking of complication. I mean pitfalls, limitations of the sentinel dissection. Like okay, sentinel dissection on one side. Okay, you do it with the with technician labeled collide. So if you don't have a gamma camera, how you can pick a hot spot, right? Number one. But there are you have found out the alternative for that, and that is the methylene blue dye test, and that's so simple. You just inject and you wait for 10-15 minutes, and then you can see a blue lymph node in the region, right?
Yes,
but
sir.
the limitation is that if the lymph node is totally destroyed by the malignancies, so the lymph nodes are not going to take up the dye or the collide solution, right?
Yes, sir.
So now over to once again to Amjad. There are a lot of questions from Amjad, and their session will be followed by discussion and questions from Dr. Mansoor Ali Khan. So Maria, how many questions are there? Relevant questions from Dr. Amjad. Those questions who are not repeated or who are quite relevant to the subject. There's another comment, right? Somebody was saying, okay, do you need to remember all these different trials in the world? Okay, if as a part 2 candidate, if you asked from the examiner what about the different trials and disadvantages, it means you have already crossed, you have already passed the bridge. And you might be familiar with the fact that some of the candidates, they have topped the session, right? So it's for those who are topping it, right? So for top positioners, these are the different questions which can be asked in addition to the basic questions. So don't be afraid of these difficult questions. They are just for your higher ranks.
And with regards to trial, if I make a comment, you don't have to remember every single trial. Whatever you are saying, your answer, whatever the recommendation is, for example, there are trials which confirm the usefulness of the sentinel lymph node biopsy. You should know them. If for example, micrometastases, you should not be treating micrometastases. Then if you're saying that, then you should be backing it up. The trial is IBCSG23, something like that. So that's the trial which confirmed that micrometastases, if you leave them alone, the survival is the same. So whatever the way you're managing a patient and you're making a statement, and this is what I would do, then the examiner might ask you and might challenge you. So you should just remember the trials that actually are called landmark trials, which define the current day practice.
Thank you. Maria?
Something, sir? Yes, sir.
Maria, please ask questions, but you mentioned about the candidate or the participant who is asking, and preferably the workplace where she is working.
So Dr. Bushra from JPMC is asking that if ultrasound shows a cancer, and you have to do mammogram in every case, even if it's less than 35 years.
Yes, the reason for doing mammogram is, one, obviously you get more information, and the more information you get is ultrasound. If you're looking at ultrasound picture and if you get looking at ultrasound report description, that is completely different than as a surgeon looking at the mammogram, planning your surgery, exactly where your tumor is, how big the tumor is, the location of it, the distance from the chest wall, the distance from the skin, and you actually plan your surgery and your incision and your whole procedure based on how it looks on the mammogram, not on ultrasound scan. The other thing is, ultrasound is a mobile scan, so it's as good as the operator has seen. But mammogram can tell you whether it's multifocal disease, it can be missed from ultrasound, how far apart those lesions are. So the exact location of the lesion, the size of the lesion, the relative position to the chest wall, to the nipple, to the skin, and the multifocal or multicentric nature of the disease, for that you do need mammogram.
Thank you, sir. So Dr. Sundar Tariq is asking that what are the indications of staging? So I think it should be the advanced type of staging, including CT.
It's very clear. So if you look at the TNM, so T3, T4 tumor, T3 is more than 5 centimeter, T4 is any size which is invading the chest wall or the skin. So T3, T4 tumor, clinically palpable axilla, not N1, N2 or N3, because you know that exactly when you do surgery, and if you haven't done surgery, you can't be sure. So positive axilla, clinically positive axilla, T3, T4 tumor, inflammatory carcinoma, recurrent tumor. So if a patient has had surgery before and treatment before, and 3 years later on presents with even a 1 centimeter tumor, because it's a recurrence and it's coming in locally, it can come at a distant site as well. So every recurrent tumor needs to be staged as well. And the last one is symptoms of metastatic disease like bone pain or deranged LFTs and things like that.
Okay. Thank you, sir. There are questions related to mammogram. One is by Dr. Faiza, that what are the limitations of mammogram and the role of compression mammography?
Okay. Limitations, if you look at it, the main purpose is to not miss a lesion. So the sensitivity of mammogram is greatly affected by the breast density. And at one point, one of the studies says that if the density of the breast increases and say in under 40 or under 35, the mammogram sensitivity can be as low as 50%, which is as good as tossing a coin. And at peak, your mammogram sensitivity is around 95, 97%. So the limitation is that mammogram is not 100%. It can miss lesions, especially it can miss invasive lobular carcinoma. Compression views are done when you have a very small little lesion, and there is a difference. You can't differentiate whether it's a true lesion or it's an artifact. So you do a magnified view or a compression view to further enhance and get more information about. So if mammogram 100%, it has information, and for smaller lesion, you might get magnifying views or compression views.
All right, sir. And for mammogram, so there is another term, the 3D mammography, tomosynthesis. So when would you recommend that?
Depending on whether you have the facility or not. If you, it's like when would you want a 20 megapixel camera and when would you want a 10 megapixel camera? If you can afford a 20 megapixel camera, why have? So 3D mammography is definitely better than the digital, and digital is a simple digital, and digital is definitely better than the previous analog one. So if you can afford it, fine, why not?
Okay, sir. Thank you so much, sir. So there's another question. If there is an unknown primary, if the enlarged lymph nodes in the axilla turns out to be adenocarcinoma, then what would be the...
It's a difficult situation, but it has to be managed. And one thing that we missed is every cancer should in a breast MDT, and all these decisions should be made, even if it's a simple case, should be made in the breast MDT. So from the imaging point of view, if mammogram in ultrasound is negative and there are nodes in the axilla and it comes back as positive, the first thing I would do is do MRI, because MRI is much more sensitive than ultrasound and mammogram, and it is possible that it might be just an invasive lobular carcinoma, which is also sometimes called as occult carcinoma, which is not visible on ultrasound or mammogram. So the first thing is I will do an MRI scan. If there is nothing on MRI scan, then the next thing you should do is you will do tumor markers. So the breast tumor marker, you have CA15-3 and you have 27-29. These are specific for breast cancer. So you will do tumor markers. And other than, I'm afraid if there is lack of, you would do other tumor markers as well for pancreas and for other. So if you don't get any or any evidence of any cancer on MRI, on bone scan and tumor markers, and the only node which is suggestive of adenocarcinoma of the breast, then you just have to treat the axilla and then monitor. The important thing is whenever there is a difficult case or difficult situation is to involve the patient in the management and planning. And the way you involve the patient is that you tell them clearly what we know that in metastatic disease, which according to the test is more likely coming from the breast, problem is we don't know where it is in the breast. The imaging is not showing it to be in the breast. So we're not sure that if it is in the breast or not. The options are treat the axilla and follow up the breast, or treat the axilla and the breast both. Both have consequences. So if you don't treat the breast, well, obviously it can come back later on. The advantage is that you will have a better cosmetic outcome. The disadvantage the advantage of treating the breast is you do surgery and you might be lucky, there might be cancer. But what if you do a mastectomy and the histology says there is no cancer? So the patient should be aware of that, because then you don't want to be in a situation where you've done a mastectomy and the histology says there's no residual, there is no breast tumor, and then you're explaining that to the patient and the patient asks, well, why did you do the mastectomy then? So these are difficult situations. The follow-up is, the way is you do MRI, you do tumor markers, you exclude other cancers, and if there is no indication of anything else, you admit that there will be limitation of the treatment, explain the pros and cons to the patient, and then make a combined decision.
And that was very elaborate, sir. So there is another question by Dr. Amalia, that the duration of tamoxifen after ATOM trial, has it changed from 5 to 10 years, or so is there's some controversy?
Original trials, and now they've changed. So endocrine treatment, I think there is a lot of trials in that. The first thing is premenopausal initial advice was give 5 years of tamoxifen. Now that has changed to 10 years of tamoxifen. The initial advice was 5 years of aromatase inhibitors, which include Arimidex, anastrozole, letrozole, and exemestane. That is changed to up to 7 years. And the advanced the disease, the more advanced the disease, if there's lymph node involvement, they advise to give at least 7 years of that. But there's another thing. There is a text trial, and there is I forgot the name of the next one. So there is evidence that in postmenopausal women, after the ACE inhibitors, they work better than tamoxifen. So the area they've explored is, what if you induce menopause? So what if you do ovarian ablation, either chemical or even surgical? So those trials looked at patients who are in their 40s. They were premenopausal patients. They induced menopause in them, and then they compared tamoxifen and ACE inhibitors. And even in those patients, whether the menopause is natural or induced, ACE inhibitors are better than tamoxifen. So you would see patients who, this is one of the options that oversees their patient as well, to just have chemical or surgical ovarian ablation and then go for aromatase inhibitors.
Yes, sir. So there is a question by Dr. Wali, that if the sentinel node shows 2 macromets in stage 2 cancer, should we proceed with dissection or chemo or radio?
That is the current debate at the moment. The Z11 trial, the American Z11 trial, according to that, you
Yes,
can
you already mentioned.
The controversies about that trial and why it's not accepted worldwide is that, number one, all who they put in the no treatment arm, they had breast conservation surgery and they had radiotherapy to the breast, and there is evidence and there is data to suggest that the no treatment trial actually had radiotherapy. Some of them had radiotherapy to the axilla as part of the radiotherapy to the breast, and we know from the MRS trial that radiotherapy to the axilla is considered as treatment of the axilla. So that's not a no treatment arm. The other thing is 44%, if you look it up, 44% of the patients in the no treatment arm had micrometastasis. And we know that trials suggest that for micrometastasis, you don't need any further treatment. So although there is some evidence from Z11 that you can leave 1 or 2 positive nodes, it's not widely accepted, and I personally offer them treatment, be it radiotherapy or axillary node dissection. Both are the same, but I would offer them treatment, either radiotherapy or axillary node dissection.
So another question. So I think we will take this last question, and then we can hand it over to Dr. Mansoor, who can please brief us regarding the reconstructive options as well. And then if any queries, as that is your expertise, so if any queries, then that should be discussed. So there's a question that, is there any change in the definition of multicentricity and multifocality based on AJCC 8th edition?
The latest edition, I'll be honest, I haven't read that definition myself yet. Um, the usefulness of that is that the big debate about multicentricity and multifocality is whether you can offer someone breast conservation surgery or whether you should go for a mastectomy, and that varies. There's no consensus on that. Some of the surgeon, it basically comes down to how comfortable you are and you with your skills, because if you have, how many incisions are you allowed to make on the breast, and whether it leaves a possible residual tumor or not. Generally, most of the surgeons would say don't do breast conservation in multifocal, multicentric tumor. There are some brave ones out there who would still venture out, but it's you have to explain it to the patient. But if you're asking specifically about the definition of the multifocality, multicentricity, somebody's kindly helping us. It's the distance between the two focus, and it's 5 centimeter. I'm not sure if that's changed in the latest 8th edition or not. I haven't read that definition.
Thank you, sir.
Thank you very much, Amjad. Very elaborative, very detailed discussion about breast carcinoma. I think there's much to say about and there's much to discuss about, but due to time limitations, we will stop this discussion here and we will move on to another part of this discussion, that is the reconstruction. Breast is one of the most important and aesthetically important structure, and reconstruction has got a basic role in the surgical modality treatment for carcinoma breast. So now over to Dr. Mansoor. Mansoor is a kind of person who is well versed with the modern technology and lot of equipment. So, but we are so simple, Mansoor. So we cannot hear you properly.
By Farah, very descriptive, and everything was to the point, and very well conducted by Dr. Amjad. We can all learn a lot from him. He's a very good consultant oncoplastic surgeon. So there are a few things which I want to discuss, and I want to bring into the change of the pattern. First, while presenting your case, you should present your objective findings, what you ask from the patient, and that you have told the examiner. Then the second thing on the examination, that is the subjective, what you see on the patient. Then leave the rest to the examiner, that he should ask you, how will you go with the case? Like investigation, you cannot do in the examination. That's how the examiner will lead you to the discussion. After the examination, all you can do is to just summarize your case on the basis of the history and examination. Then after the investigation detail, which was discussed thoroughly by Dr. Amjad, and it was very good, I learned a lot from that. Then you should leave something to the multidisciplinary board, which you didn't take any mention of that. So while he was asking about what you will do, then you should discuss things with the oncologist at least. So he will tell you whether you need neoadjuvant or you need adjuvant therapy in that case. Then you didn't counsel the patient at all at the end, before the treatment, going into treatment, because there are a lot of concern of the patient as well, whether they need the conservation therapy or they need for aggressive things. So you have to like highlight that thing as well. you have to put the ball in the patient's pocket. What does the patient needs? You are not supposed to like impose your treatment options on the patient. So you have to discuss, you have to counsel the patient, whatever he wants, you have to go for that. Then you have to like sort out the way how will you go with that. Actually, I'm from a different specialty, but as far as I know, the CPSP exams, that's how it goes on. So I'll give you like 10 out of 20 marks, which is not a passing marks in this case, because the pattern was not good. Your knowledge was very good. I'm impressed. So now coming to the breast conservation therapy.
You
So
are the
should
worst
we talk
examiner, Mansoor.
So actually, the pattern was not good. I didn't like the
I'm
way
just
the
kidding. I'm
Farah
just
goes.
kidding, right? Okay, yes, you're right.
Actually, Amjad was
This discussion, the aim of this discussion to put the candidate on the right path. And
right path. Exactly,
it's
sir.
right, right. I
Dr.
totally
Amjad
agree
was
with you.
very like a good examiner. He was putting the candidate on the path again and again, but she was like in disarray. That's how. That's why she didn't get away with the question as well. Like if he asks you whether you will go for the new adjuvant, you should have answered like you will discuss with the oncologist. So this is not my job. This is oncologist. Then the examiner asks you, okay, you discuss with the oncologist, but what is your thoughts about that? Then you can answer your thoughts. But that's how we go. So should we go with the uh, reconstructive option, sir?
Yeah. I mean,
Okay.
this long case is finished now, and obviously every surgical procedure like this one is followed by reconstruction and cosmetic outcome. So, brief discussion about that.
Okay. This breast conservation therapy is all about improving the aesthetic results. Basically, it was initially launched in like 1993 to improve the cosmetic result. Whenever you remove a small tumor, it leaves some deformity to the breast. So like after removing every small tumor, like doing lobectomy, segmentectomy, the patient's ratio is in 20s to 30s when they come back for you to for the secondary procedures. And when you go with the radiotherapy ones and then the patients come back, then the problem is that you cannot reconstruct that properly, which you have done in the first hand. So that's why they bring with the thought that we should go with the breast conservation. That is an oncoplastic concept. The breast conservation is basically removing the tumor, rearranging the tissue, and going for the radiotherapy along with that. When removing the tumor, as Dr. Amjad mentioned, there are multiple ways. The one way is either you do it with the frozen section control. That is, you remove step by step the tumor and you assess when the margin is clear, like in millimeters, then it's enough. If you do not have that frozen section control segment in your treatment facility, then you go for like 1 centimeter margin or 2 centimeter margin. There are a lot of controversies in that. So at least at the end of the day, when you do the uh, this histopathology, the margin should be histopathologically 2 millimeter clear from the specimen. So that is 2 millimeter. If it is less than 1 millimeter, then you should go for the re-excision or reconsider your treatment. This is one thing. Then when going for the uh, breast conservation, then you have to correct the deformity as well. Then we divide the breast into multiple segments. Some are the favorable locations like the lateral, upper, and lower, and some are the unfavorable locations like the medial part of the breast, in which a small deformity will become a bigger deformity that will be visible and the patient cannot tolerate that one. So, and then it depends on the size of the tumor as well and the size of the breast as well. If there is a small tumor in a bigger breast, that will create a lesser deformity as compared to a bigger tumor in a smaller breast. Like in a small breast, 15%, 10 to 15% resection will leave, you can go for the conservation, rearranging of the tissue with good cosmetic results. With a bigger breast, 30%, it can be like up to 30% scope. So if you have a small parenchymal, you have a small breast or medium-sized breast, and there is a small parenchymal defect, then you have to look at the location. If it is like in a favorable location that is lateral or superior, then you can do local tissue rearrangement. And then if it is in an unfavorable location, that is the inferior pole of the breast or in the medial side, then you see whether the breast is stautic. If it is stautic, you can do this vertical reduction techniques that we apply, the vice pattern or the donut shape. Then if it's like if it is unfavorable location but non-ptotic breast, this breast is small, that you don't have much tissue to reconstruct the breast from itself, then you can do like a flap coverage like from the LD. Then we have another flap that is emerging flap, the TAP flap, the TDAF flap. Then we come to the large defects in the small breast or the medium-sized breast. Then in those cases, when it is larger, then we go for the LD flap or the TAP flap. Then if we talk about the larger breasts, in which are more forgiving for the resection, then we will see if it is small size parenchymal defect that is less than 15% in a large breast, you can do local tissue rearrangement. And if it's like medium sized defect that is 15 to 30% of the parenchyma, then local tissue arrangement or reduction mammoplasty techniques can be applied. Then if there is a large defect, more than 30%, then reduction mammoplasty, local flaps like the latissimus dorsi as a TAP flap can be applied. There are multiple flaps in the surrounding areas which are more emerging, like the intercostal artery flaps, the lateral intercostal artery flap, the anterior intercostal artery flaps for different locations can be applied as well. So now, if somebody has, there are multiple terminologies which are like confusing, and Dr. Amjad can help in this one as well. Like one is total mastectomy. Total mastectomy is something in which you remove the skin, the breast tissue as well, all of the breast tissue. Then there are like skin sparing mastectomy, in which you leave the as much as skin as possible to reconstruct immediately the breast and leave the parenchyma as well, along with the fascia of the pec major as well. Then there is another terminology coming up, which is nipple sparing mastectomy. There are multiple problems with the nipple sparing mastectomy. One is the involvement of the nipple areola if we have a tumor. So it increases the chances of the recurrence or the residual tumor as well. So these are recommended for those tumors which are very, very small remote tumors, identified by chance or by investigations, or in those patients who requires prophylactic mastectomy, like the BRCA1 and 2 positive patients, or these basal type of the tumors in which all are negative. So nipple sparing mastectomies usually are for those patients who have very small remote tumors, or who needs prophylactic mastectomy, who can develop a tumor. But in these patients, you have to counsel the patient for the loss of the nipple areola complex, or if you find a tumor which is very near, or you suspect can involve the nipple areola, you have to remove it. So you have to counsel the patient beforehand for the loss of the nipple areola complex. So there are multiple incisions placement. Actually, the whole concept of the oncoplastic is the application of the plastic surgical principles. That is one placement of the incision where you want to place an ideal incision. And the second one is application of the mastopexy and the breast reduction techniques to the reconstruction of the small defects to avoid these deformities, post-operative deformities. And there are multiple techniques for the rebalancing of the contralateral side as well. So these incision can be actually like elaborated in a presentation type of difficult thing. These can be radial in some portion, areolar in some portion. There can be like, if you want to remove just skin sparing, you can go with areolar incision. And if there is a tumor which is very close, like 1 centimeter from the skin, then you can involve that portion as well along the circumareolar nipple areola incision in elliptical pattern. Then if you are performing the multiple ways of the nipple sparing mastectomy, that can be done through the inframammary fold incision. It can be done through the axillary fold incision. And there can be like a lateral incision, oblique incision on the breast tissue itself. The problems with these patients is like if you do the nipple sparing mastectomy, is access to the donor vessels as well. So the autologous tissue reconstruction with a free flap becomes a little bit tricky. So most of the techniques like most of the techniques are like, wait a minute, I have to change my headphones, sorry.
So can anyone volunteer to share the reconstructive options with us?
Once Dr. Mansoor is finished, I would want 1 or 2 minutes once Dr. Mansoor is finished.
Yes, sir, sure.
Hello? Hello?
Yes, sir.
Yes.
Can anybody listen to me?
Yes.
Yes, we can hear you.
Okay. So far we have gone to the nipple sparing mastectomy incision placement. So we can go through the inframammary fold incision. And then let me mute. Okay. See, there's a lot of echo in my ears from this. So these are the incision placement, inframammary fold incision for the nipple sparing and the axillary one as well. Then coming to the reconstruction. The reconstruction can be immediate or delayed. If we assess like in these patients, we have to give radiotherapy. That is a very important factor in the deciding whether we have to reconstruct immediately or we have to leave the reconstruction. Obviously, in the breast reduction, the breast conservation therapy, we have to do it like immediately. But in those cases in which we do the nipple sparing or the skin sparing mastectomy for the early cancers or the prophylactic mastectomy, we have to decide how do we have to go. If we decide to do immediate reconstruction in these patients, the radiotherapy can have an effect on the flap size. It can shrink the size of the flap, leaving the patient with asymmetrical breast. So our strategies are to increase the flap size by 20%. So at the end of the day, when it becomes shrink, it becomes at the same size of the contralateral breast. Most of the plastic surgeons usually leave it to a secondary procedure. Because secondarily we can better assess and give the proper volume which the patient needs. Then there is another discussion about the implant-based reconstruction, whether we should go immediately or delayed. If you go delayed, then the apron, the skin apron is all fibrotic and it is not giving, it cannot be expanded. So it is kind of a difficult scenario. So whenever you want to do implant-based reconstruction, the proper way to go is to place an expander implant, which is silicone plant type of thing, which we gradually expand. First, we occupy the pocket, then we can expand it. And like after 4 weeks, when we have achieved the proper expansion for the implant, then we can, if we need the expansion at the first place, then we can start the radiotherapy. When the radiotherapy is complete, then we can remove this expander and we can replace it with a permanent implant, or we can leave that expander implant as well. Or if we have to do implant-based reconstruction later on, then we have to do a flap as well at the same time. So these are all about the reconstructive option. There are multiple flaps. If all the candidates what are the basics for the general surgical candidates? The first one is LD. The LD flap is thinner. It doesn't have that much volume. If you are doing it for a small breast, then it can provide the volume. But for a medium size or a large breast, it is usually insufficient in volume wise. Modifications in that flap as well, you can do extended.
Mansoor,
Okay,
there is a suggestion by one of the candidate from Karachi that if you have got a pictorial presentation, that will be far better them to understand.
Sorry, sir.
If you can draw a picture on.
Actually, I haven't prepared one. I was not prepared for the presentation, in which we identify perforator just to the skin and take the skin, we dissect it out through the muscle to spare the muscle, and we leave the nerve as well. So, that is with lesser mobility, but technically more difficult, demanding. These are thinner flaps. We can take flap with that as well, provide the volume. Then the workhorse flap for autologous reconstruction is tram flap. That is transverse abdominal flap. So in this flap, these are in those patients who have paniculous abdomen, hanging abdomen. We can utilize their tissue to reconstruct the breast. It can be a pedicle flap. We can base in on superior epigastric artery and take the subcutaneous tissue and the skin to the breast. And it can be a free flap, which can be a tram flap, which can be a perforator-based flap. So these are the major flaps utilized. But in exam, if somebody has, the patient doesn't want a scar on the back of the during reconstruction, or he doesn't have abdomen enough to reconstruct, or he doesn't want a scar, there are multiple options as well, which are mostly free tissue transfer, like the S-gap from the buttocks. In the lumbar area, there is another emerging constructive option, the lumbar perforator flap. There is a tug flap that is based on the gracilis arterial supply, which we can take a horizontal skin pedal, or we can take a vertical skin pedal, and we can reconstruct there are multiple advantages and disadvantages. Now, where do we anastomose in the breast area? The ideal vessels are the internal mammary vessels, but are difficult to access. They're on the medial size, and you have to excise one rib or two rib to get access to these vessels. Now, there are techniques developed to anastomose without dissecting the rib, but these are technically difficult. Then we can anastomose these with the thoracodorsal as well, but these are far away in the towards the axilla. You need a longer pedicle, and the orientation is difficult of the flap. So you have properly located the pedicle and you design the mound as well. So the mound wise, the orientation wise, the internal memory and the largest caliber size wise, these internal memory are very good. But technically demanding, the X is demanding. So if we talk about the S-gap flap or the lumbar artery flap, the pedicle is very small. So whenever small is, there is a tension on that. So what we do, we place the vein grafts. Nowadays, they take the vessel of the inferior epigastric artery, which has both the artery and the vein, like interpose it in the recipient vessel and the donor vessels, so increase the size. After that, once these things are done, then the reconstruction of the nipple area comes. That is the stage of
sorry to interrupt you. So there are a few related questions. Can I ask in between? Sir, about the anastomosis.
It is almost finished. We can go to the question answer.
Okay, sir.
So then we reconstruct the nipple areola complex. For the areola portion, we can tattoo it, or we can graft a skin graft. If we put a skin graft at that location, it darkens its natural course and gives the impression of the areola. And we can reconstruct the nipple with different techniques like the secondary flap over flap technique, star-shaped flap. We can put a cartilage underneath the skin to give the impression of the nipple. There are multiple ways to do the nipple areola complex as well. So that was a brief account of the reconstruction. Now we can go to the question answer.
Thank you very much, sir. That was very elaborate. Sir, there was a related question about the anastomosis, that during microanastomosis or the general anastomosis, what do you do first, the vein or the artery?
Okay, it depends. Every way is all right. All right. Some prefer the artery first, some prefer the vein first. Then there are technical issues. If you have like a deep vein, you do it first. Because if you do a superficial artery, then you will have a difficult access to the vein. Then surgeon preferences. Most of the surgeons prefer the vein first. That is when you anastomose the artery, it will bleed, and if you clamp it, then it can lead to the stasis and the coagulation of the vessels. And some prefer the artery. Why? Because you don't, in situation in which you cannot tolerate a longer ischemia time, like in the muscle flaps, you do the arterial first, so the flap becomes perfused. Meanwhile, you can have time and anastomose the vein. What we do, we anastomose the vein first. So when you, at the end, when you come to the artery, you don't have bleeding, and it is easier. So
Mansoor, just a minute.
Basically.
Okay, sir. Yes,
Mansoor, just a minute. Next time when you come to presentation, you have to show us a short video microvascular anastomosis, which you do in your department under that megapixels of camera and microscope, right?
Sir, actually, yesterday we performed very good LT flap with very good vessels, and we have this good microscope with a digital display.
I know about you, the microscopes and the instrument you have here in your department. They're the excellent ones. But next time we would expect you to have a video clip, a short
video.
Actually,
I was not sure that I will be doing a presentation. Actually, okay, I'll do it next time, inshallah.
We will make arrangements, special arrangements for that next one.
Okay. So just take 1 minute with your permission, sir.
Yes.
First of all, I feel for Dr. Mansoor because he had to explain reconstruction just by talking. And even when you see reconstruction so many times, it's difficult to get your head around what goes where. So it's a difficult task, and I also feel for all the audience. So just few basic terms. So in terms of mastectomy, you have simple mastectomy, you have skin reducing mastectomy, you have skin sparing mastectomy, you have nipple sparing mastectomy. Now, which one to choose and where? The mastectomies that we do all the total mastectomy or the simple mastectomy, where you remove the breast and suture the skin, that's simple mastectomy. When you're doing reconstruction, then you have to split the two different. You have to consider the skin envelope separately, and you have to consider the breast volume separately. So if you have if somebody has a larger volume breast or a larger sagging skin, in that case, there is a limit how big reconstruction you can offer with the implant or with the flap. There is a limit. You can't go too big. So if somebody is big or has a bigger skin envelope, you do a skin reducing mastectomy in which you reduce the skin envelope and then use most of the breast skin to cover, whether you're using implant or whether you're using a flap. The skin sparing mastectomy is done where the skin is not too big, the skin envelope is not too big, and you think you can fill the whole skin envelope either with implant or with a flap. So you don't have to reduce the skin, and in that what you do is you make an elliptical incision around the nipple because you are removing nipple areola complex. Now, the question is, can we leave behind the nipple areola complex? And that is the nipple sparing mastectomy. So we do that, as Dr. Mansoor said, in prophylactic cases. You can also do that in DCIS, in situ carcinoma, not in invasive carcinoma. But there is some study which says that if the tumor is at least 2 centimeters away from the nipple, you can still do nipple sparing mastectomy, but that's again a brave thing to do and a controversial thing to do. The reason is that invasive ductal carcinoma, when you're doing a mastectomy, you try and remove all the basically intramammary ducts, and you cannot remove the ducts inside, the major ducts inside the nipple. So you are leaving a slightly increased risk of local recurrence. But nipple sparing mastectomy is again done in prophylactic scenario, in DCIS, or you can do it if the tumor is more than 2 centimeters away and you are slightly on the braver side. And the way to decide which one, it depends on how big the skin envelope is and how much volume you can give the patient, either with the implant or with the flap.
According to the terminologies, different authors have different views, but almost the same that we mentioned. Then coming to the nipple sparing mastectomy, the occult cancer, that is residual tumor, according to a study, if you do it, like in 30%. So it is, as Dr. Amjad mentioned, it's a very brave thing. One thing that we have in hand, that is the frozen section control, which is usually not available in every center. That's why whenever you're going for the nipple sparing mastectomy, we have to counsel the patient that even in situ or a very early tumor, we can lose the nipple areoloma, whether to the extirpation or to the vascularity loss, vascularity compromise. So it is a very brave thing. So mostly reserved for the prophylactic one. So then coming to the breast volume, how much you can reconstruct. Depends. If you have a volume and you can provide and you discuss with the patient how much volume does want, because we have an option. That is the contralateral balancing procedures. You can always balance it to a smaller size. So you discuss with the patient and then go for it. And then the skin apron limitations. You cannot leave a long skin apron without compromising the blood supply. So you have to balance all these things. And next time, Dr. Amjad, you are right. The reconstruction is like, it should be very pectoral and graphical. It cannot be like done through just talking it out. So actually, I thought that you'll be speaking and I'll be listening.
Okay, Mansoor, there's another question. Can you use other things other than these silicone implants?
Sir, we have saline implants. There are a lot of debates going on, which is not like should be part of this thing. LCL, like tumor lymphoma, which is associated with silicone implants. So nowadays, most of the surgeons are like switching to this the saline implants. Okay, Dr. Ram just want to say something. Better person.
I'm just
There is another option which is very good. Not everybody is a candidate, but we've done it in the UK very regularly. It has better results than implants in suitable candidates, and that's fat transfer technique. So you basically do liposuction from around the tummy, from around the back, the hips area, and then you, after reconstruction as well, for example, you can do that with an implant as well. So fat transfer is a very good technique to give breast volume. It's very simple. The problem with that is because in cosmetic setting it works differently, but in reconstructive, your LD is not volume. You can just reconstruction, and at a later stage you can fit behind the LD flap with a lot of fat transfer, and that usually works well. So an alternative to implant is fat transfer.
okay. I mean, two in
Exactly. It's a
one,
very,
like
very good one.
abdominoplasty and mammoplasty in the same setting.
Once. Once. It's a long surgery, and actually when I did that, it was a joint venture. So I had a plastic surgeon who was dealing with the tummy, and I was doing the other bit. Because if you look at mammoplasty, will take you, depending on which type of mammoplasty you're doing it, and if you're doing bilateral, it will take you 3 to 4 hours, and then you add to that abdominoplasty. So then the recovery, that is affected, and you don't want any complication in plastic and cosmetic surgery at all. So you want to keep that minimum. But because that patient had traveled from far away, we had explained everything, that this is the reason we don't do it, and she was willing to take the risk, so we did it, but it was just once.
All right. Excellent. I mean, it's a critical type of MDT.
Yes.
Okay, there's another question from Dr. Mansoor. Which reconstruction is best one, immediate or delayed one? This is a question from Dr. Bushra from Karachi.
Immediate reconstruction is better with autologous, because the play better tolerate the post-operative radiotherapy. But we have to increase the size like by 20%. So when the radiotherapy shrinks the flap, it becomes like what we need.
I'll just add to that, because the reconstruction, the aim is that the patient should be happy. So if you look at the literature, patients with delayed reconstruction, they are much more happier than immediate reconstruction. And the reason for that is that the patient who have delayed reconstruction, they live with a flat chest for a bit of time. So when they get a reconstruction, they are happy. But if patient who have immediate reconstruction, you're replacing their normal original breast with a reconstructed one. And it's very, very important that their expectations are realistic, because then going from the normal one to a reconstructed one, usually they are not as happy and satisfied as the delayed reconstruction patients.
This is a very important question. Other side of this narrative is, like, if you do it immediately, the patient will always be in doubt that you have left something behind. There was a patient while I was working in KTH, we did an immediate reconstruction with a time flap. It was a beautiful reconstruction, but she was always like ending up in our ward and complaining like things, and we have to do a lot of investigation to sort out whether she has something or not. So delayed reconstruction is a better thing, but they are like always the patient's what the patient wants. You have to follow that, and you have to counsel her accordingly. That what are the drawbacks.
Okay, dear participants, if anybody wants to ask question their own voice, they can do so by unmuting themselves.
So there is a question that where exactly do you replace the silicone implants? And what if the patient is allergic to silicone transplant? Are there any other methods of these reconstruction, this type of reconstruction by implants?
The second part, Dr. Amjad rightly mentioned the fair transfer, autologous reconstruction. You can do a flap, whether the volume is small, then you can always top it up with fair transfers if the patient have it available. Then the first portion is there are multiple, like a discussion, a debate where you have to put the implant. You can do it this if you do the if there is mastectomy, there's another scenario. If you don't do the mastectomy and do it for the breast enlargement, then you can put it subglandular. It has advantages of better projection and natural feel. If you put it behind the this pec major flap, then it gives unnatural feeling and the projection is not that good as a subglandular approach can give you. To solve this issue, they have devised like a hybrid plant for this, in which they spread the muscle. Some portion of the implant comes behind the gland and some portion is behind the muscle. Why do we put, why it is necessary to put the implant behind the muscle? First thing is, if the skin pinch is like very small, less than 2 centimeter, then the implant will be very visible and you cannot hide it behind this gland. So you have to put it like somewhere where you can hide the implant to avoid the unnatural look. But if you put it behind, then the drawbacks are like it doesn't give the projection properly. Then if we like the drawback of the subglandular is the rippling. If you put a saline implant, it gives you the ripples which are more visible behind just the gland. If you put it behind the muscle, these are not that visible. So these are the multiple ways to do it. First is like submuscular, the second one is subglandular, the third one is the hybrid to solve these problems.
A question by Dr. Zakir and Dr. Ahmed Shahzad that if you are left with deficient skin after modified radical mastectomy, how do you close the skin and how much minimum gap can be closed primarily?
Usually the breast is like expanded skin due to breast tissue. So in the normal non-expanded skin, when we take a flap from a donor side, we can close like 7 centimeter primarily in the thigh, in the abdomen, depending on the area. But breast is expanded skin and different people have different sizes. So you cannot like say that this centimeter can be closed primarily. The second portion of the question is like if we left with the deficient skin, then you can close it with a flap. Don't do closure under tension. It will leave your remaining flaps necrosed.
And so there was another question regarding the flaps, that how do we monitor it for recurrence?
In the flaps, the monitoring is like the same. It doesn't change much because these are, if you do it with autologous reconstruction.
That could be by MRI, sir, or
MRI is a very good thing when you reconstruct with different things with the silicone implants. You cannot like properly do it with the mammography. In the mammography screening, we can put different views along with the standard 2 views. You can do it with that, but whenever you are suspicious, it can be done better with the MRI.
Thank you, sir. If anyone has any other question, they can unmute themselves and ask.
Let us, Dr. Amjad, talk later.
Yes, sir,
so we
Dr.
can learn a little more
Yes,
about it.
Dr. Amjad.
I just wanted to thank Dr. Zareen and thank everyone, the participants, and with the permission of Dr. Zareen, if it's okay, I would like to say thank you to all of you at this point, if it's okay.
Okay. Thank you, Abjad, for coming and joining and for sparing your time. See you again, inshallah.
Inshallah. See you again, sir. Thank you.
Thank you, everybody. Sir.